My name is Rachel Stevenson, and I'm the Events and Social Manager here at Identity Automation, and I'll be the moderator for today's discussion. So today, our expert panelist is Scott Breece, Vice President of Security and Chief Information Security Officer at Community Health Systems. We are also joined by several of Scott's Community Health Systems team members. In today's discussion, Response to COVID-19, an open forum with Community Health Systems, we're facilitating an interactive environment for IT personnel in the healthcare industry to come together with expert panelists to exchange questions and ideas on how to manage the challenges that healthcare is facing in the light of COVID-19. We encourage you to unmute yourself and join the conversation with questions and insight throughout the forum. I'm now going to pass the mic over to Scott for him to give a brief overview of his career and time at Community Health Systems, and then we'll jump into the discussion. Scott?
Good afternoon, everyone. Hope everyone is staying healthy and safe. I have over 17 years of experience. Formerly worked at Hospital Corporation of America, HCA, prior to my 12 and a half years of experience here at Community Health Systems. We as a group, and by the way, in the room here, we have the list of panelists. I'll give them an opportunity to introduce themselves that are on my team and that are participating with us today. So if you would, go ahead, Mike.
Hello, I'm Mike Combs. I'm the team lead for the Identity and Access Management Program here at CHS. I've been with the company for about 16 years now.
My name is Heather Mills. I'm the Manager of Security Risk Management at CHS. I've been with CHS for 7 years and have 5 previous years of healthcare experience prior to that.
My name is Tom Cooper. I manage the Security Services team. I've been at CHS for 2 years.
My name is Josh Morgan. I manage the Threat and Vulnerability Management team here at CHS. I've been with us for about 6 years.
Hi, my name is Raymond Baxter, Director of Security. I have approximately 13 years of security and compliance experience.
Josh McElwain, Manager of our Security Solutions team. I've been with the company right around 4.5 years.
Jennifer Ernest, I'm Team Lead of the Security Solutions team, and I've been here for 2 years.
Thank you all for joining us today. One of the big things we noticed as we went into COVID-19 here at Community Health Systems was obviously in our acute care facilities, a lot of our elective services were shut down, and we were trying to enable our caregivers the ability to still interact and engage with our patients. And so telehealth was a significant request that we saw come in, and really a multitude of solutions were presented to us. In our organization, we perform a vendor security risk assessment on those solutions before they're implemented into production. And one of the things that we did was, based on the number of requests that were coming in for Doxy.me, Zoom, Google Meets, Google Duo, Amwell, just to name a few, we decided that we would standardize on the telehealth capabilities we were going to provide. And during this process, we identified Google Meets because we are a Google Productivity Suite consumer, and Amwell was a pre-existing telehealth platform that we use in our transfer center, and then Athena One mobile app was the third one that we chose as our standard because of our deployment of Athena across a lot of our clinic locations. So we still get some of those requests coming in today, you know, for hey, can we get a vendor security risk assessment done on this because our physicians want to use this or our clinicians want to use this, and so it's tapered off now recently because of the communication across our 85 hospitals that those were our 3 standards to use as we go forward. Was anybody else seeing those types of requests come in the door pretty quickly? Leading into telehealth, from telehealth into mobile device management, we saw some struggles with being able to manage some of these apps through our technology. Okay. Did anybody have any conversation to add to the telehealth portion of it?
I think one thing that we saw, this is Josh McElwain, I think the one thing that to add on to what Scott was saying, one thing that we saw was kind of an influx of requests of different types of telehealth platforms was the big issue there because, you know, with over 90 hospitals, vendors reaching out directly to the hospitals and doctors having their preferred methodology of doing things. So without us, so we went into this kind of blind, not blind, but there was really no standard that we had from a telehealth perspective. And then it went from a telehealth to just kind of a how do we communicate, right? From a Amwell type platform that is true telehealth down to Google Hangouts or Google Meets. And then moving into the conversation of the mobile device management, which I guess Scott will get into a little bit more. You know, we've got our standard platform for some of these applications that have been reviewed, you know, through our Citrix MDM Zen Mobile solution. And those were ready to go and ready to configure and ready to roll out. But yeah, so going back to the big issues that we saw coming in was, you know, integration with our on-prem for managed devices, which are, you know, company-owned devices, which were both laptops and even cell phones for the most part. And then with some of these other Google Meets with Citrix MDM, you know, we recently made the transitions from Microsoft Office and Exchange over to the Google G Suite of products. And with that, with the enterprise licensing, we've got the Google MDM device policy. Well, if you intermingle those two, the Google MDM policy and the Citrix Zen app policies, it breaks. So we were having facilities that were trying to repurpose some of the iPads that they had, some of the managed devices that they had, and there was conflicting set policy and configurations on that, so they weren't able to use that. So we had to come up with a solution of, all right, now that we take our managed iPads out of our Citrix Zen app solution and have that risk now if those iPads are still on our networks and don't have the same type of security policies on them that we would like for something to have on our network. So those were the big things that we saw, both with telehealth and then the mobile device management policies, our issues as this rolled out quickly.
So anybody on the call, did you experience any type of issues enabling different forms of telehealth or any other apps that may have been beneficial during this time frame with mobile device management?
Yeah, just to add to that, did anybody go in with a telehealth solution already in place and ready to roll out en masse, or already have it in masse that really helped transition to that type of treatment and deploy and offerings to their clinicians and physicians and even patients to a certain extent?
Yeah, because we did it in the moment of transition and chaos. So with limited definition around what a standard telehealth platform is going to be outside of our transfer centers, it was very stressful and very demanding at the moment that we were in it. One of the other things, one of the big things that we found during this time was, the transition to remote workforce. Here at Community Health Systems, our workforce has primarily been in the office ever since I've started here. It's been a very limited work from home policy in our organization. We implemented one about 3 to 4 years ago for employee retention purposes based on an employee relations survey, and we have a very structured process and defined requirements around it where we measure our resources progress. We do routine checkpoints. You've got to coordinate and schedule with others on the team and your leadership to make sure that we know when you're working from home and what you'll be working on. But this complete transition to everybody goes home because the office is closed was a little overwhelming from a standpoint of multi-factor authentication when it comes to remote access. And if you're not a normal consumer of remote access and you're not using multi-factor on a routine basis. The big challenge we faced was training individuals on how to use that multi-factor authentication and the different forms of it. Some of the things that we did do was bulk upload users so that we could create their VPN accounts and their multi-factor authentication. But then we also put a plan in place to monitor failed login attempts through both multi-factor authentication and through the VPN solution. This gave us the ability to target individuals with training and documentation or identify maybe threats that could potentially have compromised an account through our Security Operations Center. But what we also did was, because of the sensitivity around when we're talking about access, one of the things that we did was create reports for each one of our hospitals that said, over the next 60 days, here are the accounts that are going to expire, here are the accounts that are disabled, and just so that they could identify who the caregivers were that were on staff and treating patients, that they could avoid any type of operational impact while accessing the applications. And we still continue to produce some reporting today, even though we have some states that are transitioning back to elective services and 50% capacity across, retail, restaurants. We're a little bit different in that we have very limited hospitals in Tennessee. Most of our hospitals reside outside of the state of Tennessee. Our corporate office is here in Franklin. But we have also a shared service center model that we support as well. And each one of those locations went home and closed the offices too. So we had, not just the hospital aspect of a remote workforce transitioning home, we also had our shared service center model, our corporate employees across geographic locations doing the same transition home. So we had different use cases, but monitoring those things were key because it minimized the number of ServiceNow tickets. I didn't want to overwhelm our security services team. Tom Cooper, who introduced himself, ran that. We even transitioned into a twice-a-week open office call. And what we do with those open office calls are we spin up a bridge. We communicate to everybody that, hey, this open office call is available to you for 1 hour on these 2 days out of the week. And to avoid having to go through the ServiceNow ticketing system and get caught up in ticket routing, and maybe even into some organizations have what we call the black hole as it relates to resolution of an issue, we gave the people at our facilities direct access to our services team so that they could guide them, direct them, give them documentation, do some training with them, answer questions, and then minimize the amount of tickets coming into the ServiceNow queue. It worked out very well. Started out with a high attendance out of the gate, eventually has tapered off now as folks have been provided the necessary resources to enable local support, so they weren't having to depend on our teams here at corporate. So that was a big key for us in making sure we minimize the impact to our caregivers, but also minimizing the impact to our support staff here at the corporate office. Tom, you have anything you want to add to that?
Well, I was going to say, the process of the training and the automation that we had in place, we were expecting a spike in tickets when we first, it was like overnight that everybody was sent home. It was kind of in a wave, and we were expecting a spike in calls and tickets of people trying to get access to remote in. We had very few tickets. We were pleasantly surprised that we got very few tickets or questions about how to remote in or how to use it or just how to access different things. So I can tell you that our training was excellent, and our documentation and our process for how to an individual user to get access, it was great. So we saw a very limited number of support cases.
So, you know, a couple bullets there: elective medical services, financial impact. You know, hospital revenue primarily is driven from elective services. That's not just the emergency department, but you know, we have cath labs, we have fetal monitoring, fetal or labor and delivery. We have imaging services. These are the elective services that really drive the primary revenue for our hospital. So when those services start to slow down, because a couple things, you know, quarantine, patients fear coming to the hospital where COVID patients are going to go into the ED and don't want to contract the virus there. I would say that our hospital operators worked very well with our COVID response team here at the corporate office. They identified how many open beds, how many ventilators, how many supplies that were needed based on the projections that the federal government provided. And they did a good job at making sure that they could quarantine the caregivers into a wing in our hospitals or into a department in our hospitals. They also did a good job identifying quarantine areas for patients. I think last week during our first quarter announcement for financial earnings, the total number of COVID patients across our 85 hospitals were roughly 2,000. So we didn't have a significant spike like they saw in New York City. So I think they did a great job, you know, performing the necessary segmentation in our hospitals to protect routine patients versus those that were infected with the COVID-19 virus. But in turn, when they did that segmentation, there was an impact to a lot of those elective services. And so as we started to see those elective services shut down, obviously, you know, furlough of the caregiving staff for a temporary period of time. This week is the first week that they started to bring a lot of those elective services back online. There was a significant amount of rescheduling that occurred with the quarantine. And so they are starting to reach back out and reschedule, but it has a significant financial impact. But, you know, as a result of that financial impact, obviously, you know, we have to sit down and evaluate our operating costs. With the quarantine, obviously, one of the easy and quick wins were, you know, stopping the training and travel. That was an immediate action for us to take. We identified where we could get people to take vacation, doing some furlough associated with that. But the big thing that hit us the most is we continue to mature and grow our organization security posture. We had to put several significant projects on hold. And, you know, with that always comes like a statement of work that needs to be temporarily held or terminated, consultants that are on staff to help us get through these initiatives would be impacted as well. So we had some pretty tough overall financial decisions to make during this time, and then we're still, you know, very thoroughly scrutinizing our financial spending on a daily basis. It's not something that we like to do as part of our job, but it's something we have to do in order to maintain our organization's ability to run as a business. With that also comes, you know, balancing security risk with regulation and business enablement. During this time, the OCR, the Office for Civil Rights, and the Human and Health Services Organization lifted the certain aspects of regulations, federal regulations on healthcare, telehealth being the biggest one. Excuse me, sharing of information between healthcare organizations, providers, caregivers. There was state reporting federal reporting so that they could track, monitor COVID-19 virus and the effects it's having on different patients. So there were moments where we would normally perform a full security risk assessment, even sign an information security agreement with third-party organizations that we had to forego in order to enable folks to be able to provide patient care. That was probably one of the fewer impacting items that we had. It more frustrating not knowing exactly what was in our environment, who was using it, how it was implemented in our environment, how it was being used in our environment, that scared us the most from a security risk perspective. You want to talk about communication awareness, Heather?
Sure. So as part of COVID, there were many topics that we then had to communicate quickly from a security awareness perspective. The team already does certain newsletters and communications on a regular cadence, but I'm sure as you guys saw as well, a lot of threat actors were using this as a chance to phish, especially around stimulus checks, also to kind of, stimulate some fear, get some people to click on links when they shouldn't be, provide personal information, acting on behalf of healthcare providers in relation to COVID. And as the public itself wants more information around COVID-19, they want to click on those links. They want to know who in their area has COVID, where they should be concerned. So we had to do a lot of security awareness around reminding our end users not to click on links, be extra diligent on reviewing emails, where they come from, what the email address is, being sure that they are not clicking on attachments that did not come from a trusted source. So we do a lot of awareness around that throughout the year anyway, but we really had to pack a lot of it into the first month or two where COVID-19 was really ramping up, to remind our clinicians, not just employees of CHS itself, but also for their own personal use as well, to remind them that they're going to be hit with these types of things from not only email, but from social media, through text messages. We have seen some phishing through SMS that has happened as part of this as well, reminding them that emails may look very legitimate and could look like they're coming from within our corporation, from our executives, and for reminding them of those points that they should look at and review for every email to make sure that that truly is legitimate for our organization. So we not only participated on the open office calls that Scott talked about earlier with our support staff, but also sent out multiple newsletters to the entire organization, as well as cybersecurity bulletins as they came through to alert our end users as well as our corporate offices of sudden items to be concerned around with COVID. One of those things was Zoom. You guys probably had this as well as the Zoom vulnerability became more widely known and people started to kind of get bombed on their Zoom calls. We had to do a pretty widespread investigation and communication across our environment to let people know to make sure they're doing the upgrade to the Zoom client itself, decide whether or not we were going to allow the use of Zoom, determine where that might be an impact in our environment. So there was a lot of awareness and communication around that effort as well. Yeah.
And when good point you make there, Heather, when we found out about the vulnerability in Zoom, we had a discussion with the executives, and it was, a complete agreement that, hey, we need to go ahead and just block Zoom because we don't want to introduce any type of risk given the circumstances that we're in at the moment. But when we did it, literally not even 2 hours later, we were starting to get a high volume of calls coming in that pretty large physician groups were using Zoom for telehealth capabilities. So we quickly did some training, but Zoom was pretty quick to respond with a fix for that security issue. We then did a mass communication and training plan to get folks to update Zoom with the fix so that we could close the security risk pretty quickly. We did see some smishing attacks as well. We just recently dealt with one yesterday. That was interesting. It was more of trying to harvest people's contact information, not a significant or impactful risk that we identified, but we are seeing those types of threats coming through. We also participate in the healthcare ISAC for information sharing, and it's been a valuable piece of information. I know the financial industry has theirs. I don't know if the energy industry has one or not. But there's been a lot of useful information sharing going on between organizations in there. A lot of provided IOCs for different types of email threats that they've seen, different types of malware attempts that they've seen as well have been shared. They've been keeping up with a pretty solid communication around COVID numbers, COVID trends. They've also done a good job as communicating those organizations that are impacted by different attacks, leveraging the COVID moment. And so we've had a lot of visibility into a lot of great information, and we've armed our resources in our cybersecurity program to be able to monitor our environment very, very diligently. So that has been a great resource for us as well during this COVID-19 moment.
We do have a couple questions if y'all would like to just kind of roll through these and answer some questions.
Yeah, absolutely.
So first question, can y'all touch on your hospital's network bandwidth? Any adjustments there? And how did you handle it? And what are your plans going forward to avoid any foreseeable issues?
So we've been pretty fortunate. And by the way, just to give you a little background, we don't report into the IT organization. I report directly to the CFO. Our CIO reports directly to the CFO as well. So we are peers in the reporting structure in the organization. But our IT organization, prior to COVID-19 and our transition to G Suite, we were fortunate enough to put bandwidth monitoring controls in place so that we could understand, as we started to deploy the G Suite productivity applications across our organization, they were monitoring bandwidth during that project. That then added value in the process of us transitioning to a remote workforce. Because if there was ever going to be a test, it was having all your users at home, not internally accessing stuff externally, but the amount of stuff externally that they're accessing internally was going to be a lot different. So they continue to see, a steady increase at first, but eventually, it flatlined to an amount. I don't even remember what the percentage was, but we were fine as far as bandwidth was considered. We didn't have any reported infrastructure issues. I think most of the issues that were reported during that time period were more around user access, and I think that was just a learning curve of multi-factor authentication and VPN, especially around our shared service model. I know that a lot of times those folks do their job from 7 to 4, 8 to 5, 9 to 6, and then they go home at the end of the day and they don't sign back in. A lot of the leadership in those organizational units do, but not the actual day-to-day users. I think they were more challenged with supplying their resources with company-supplied devices to work from home with all our security controls on it. I think one of our biggest challenges was communicating the fact that you needed to have a wireless router between your internet router and your device just for extra security measures and increasing our monitoring controls in the cybersecurity space with the workforce shifting from our internal network to their homes was another thing that I think was our primary focus. But at no point was I aware of any changes made to our network infrastructure, our internet bandwidth, any WAN connectivity or bandwidth between our corporate data centers and our hospitals. And I didn't even hear of any impact as it relates to clinic to hospital communication.
That sounds great. We have a couple other questions. So someone wants to know, let's talk vendor relations. How are you all working with your vendors as demand for healthcare vendors are at an all-time high now? What's changed on that end of things?
From a technology perspective, let me say this. The biggest impact that I was made aware of during this COVID-19 moment was our ability to get supplies from the distribution centers to our hospitals. Our materials management and supply chain were the two departments that were impacted the most by that. I was aware that they had made alternative plans by leasing some key controlled environmental locations during this time to try to create a shipping hub where they could then distribute themselves to our hospital locations. But again, only having about 2,000 COVID patients out of the million that we have, it was a small impact to our hospitals. But from a technology perspective, the vendors, I would have to say, were very open to allowing us to use as many multi-factor authentication licenses as we wanted to until we get through this time period. There were others offering video conferencing solutions to our remote workforce as well. So they were good about reaching out, but the adverse effect of that is when this is all said and done, how much would we owe them for true up on licenses? I think there will be some of that in some instances of our business. We identified that there are specific business units that can work remotely now, full time. It reduces our footprint from an office space perspective, so we don't have to add additional buildings to our portfolio, and we don't have to do additional leases. And it's cheaper to provide them company-issued devices and the remote capabilities and allow them to stay at home. And it's also going to contribute to that retention that they've probably been looking for some time, because a lot of companies are going full remote workforce, not just because of COVID-19. So, yeah, vendors have been good. Vendors have been very open about, if you need anything, please let us know how we can help. Usually we see an aggressive approach to emails and phone calls, and I haven't seen that as much during this time period. I think actually my email volume has reduced, which is a good thing. But very, very open to being collaborative, to helping out and assisting any way we can. We even had vendors sending some of our caregivers meals during this time period. We saw several of those instances occur as well. So we really appreciated them thinking about the frontline people, because we were still here in an office. This leadership team that's in the room here today has been here since this whole thing started. We may have worked at home 1 or 2 days out of this whole time period, but yeah, the vendors have always been very thoughtful of not interrupting our frontline workers and asking us what we need, and then rewarding those folks with opportunities for food, and maybe gift certificates, stuff like that. So the relations have been really great, very supportive, not too intrusive, and great listeners at this point.
That's awesome. That actually answered one of the other questions that we have is how is your staff, touching on staff morale. But I also noticed that you touched on remote working, obviously for your staff, but for our healthcare workers, Have y'all had to do any community outreach, and like, have you set up any triage units or remote hospitals? And if so, have you had any lessons learned on that?
Yeah, so I've been on the COVID response team since this started, and we haven't had to do any remote locations at the moment. The first thing they did was like I said, they went through and they did a complete inventory of all the bed counts. And volumes over the last 2 to 3 years have not been great for hospital organizations, hospitals in general. And so there may have been opportunities to go through and open wings of hospitals that we may have shut a floor down because there's patient census just hasn't been that high. And so they may have used that wing or that floor to create a quarantine so that if a COVID patient did come into the ED, they were able to split the ED in a way where COVID patients would go to the right of the ED and stay on that side until they were transferred up to that floor, that wing of the hospital. But we've not had to set up any remote locations that I'm aware of. We've been in communications with other hospitals in our areas that we have a presence in, but it was more to share information about maybe a patient that they couldn't see because they were shut down on that service and we still continue to have ours open, or if they saw a spike in COVID patients coming into the hospitals, they were more sharing that information than anything else. But I don't think there was ever a time that we put a remote location in place or had to transfer some of our caregivers to other hospitals in the area to help out with COVID patients.
Okay, and we've got one last question, asking if you all had to do any staff augmentations with your doctors and nurses on site, or did you have to provide staffing augmentation elsewhere?
I never recall hearing any staff augmentation. Those were usually things that if they were significant, they were brought up during our meetings as the response team. But there was never any mention of any type of augmentation either way there. As far as going back to my staff's morale, we didn't see any loss in productivity transitioning from in the office to remote workforce. We developed 30-minute checkpoints in the morning with our staff. Everybody was very responsive, via Google Chats, via Google Meets, via telephone, via text messages, email. They were very disciplined. But the staff sitting in this room here, their morale's high enough to drive me crazy.
That is really great to hear. All right, well, we are right there at that 45-minute mark, and it appears that we're at a good stopping point. So I just want to thank Scott and all of the Community Health Systems team for joining us today and providing such valuable insight, and as well as everyone who joined us today. And for those who weren't on in the beginning, I do just want to let you know that we will be sending out a recording of today's forum to all of our participants and our registrants later on this week. Be sure to join us on our next open forum on May 13th. We will be sure to send out details with today's recording. And a big thank you again to everyone, and we hope everyone has a wonderful afternoon.